Okay, welcome everyone. I think we're live. It's lovely to have everyone along. Welcome to this evening's virtual event. We'll just give it a few minutes to allow everyone to join on. People are coming on thick and fast. I hope everyone's okay, and I hope everyone is looking forward to the event. We're going to do a presentation which will go through the general fertility journey with care, and there'll be some videos in between, and then we've got a Q&A session with our very own Professor Charles Kingsland towards the end. So I think that's enough time for most people to have joined. So I'm just going to share the presentation first of all. Just started somewhere in the middle, apologies, we'll get that to the beginning. Great, okay, so I've welcomed you all along. I'm just going to give a brief introduction as to what the virtual event is going to include. So we're going to go through diagnosing a fertility problem, an IVF treatment pathway, including the consultation, treatment with donor eggs, sperm and embryos, something about the lab techniques and some technologies that we use to help improve your chances of success, the support that we offer at care and the funding that we offer at care, getting started with care, what the first step is, and then we'll have a Q&A session at the end where we'll be joined by Professor Charles Kingsland. So we've had some questions come in beforehand. If you think of any during the event, or if you've got some lined up already, just pop them in the chat function. So you can either put them in you can put them in as a private message, or you can put them in the chat. So if you put them in the questions tab, then obviously they're private, so no one else can see your name. If you put them in the chat, then everyone else on the event can see your name, just for information. If you think of anything afterwards, or you don't want to ask a question via the chat or the questions tab, then feel free to send us an email, and that you can use the email address events@carefertility.com. So we've got a team of people behind the scenes, our wonderful new patient inquiries team. There's a few of them who will be answering some questions that they can as we go along, and they are here until 8 o'clock this evening on the phone number that I think has been put in the chat function. So if you want to get in touch with us via phone as well, then you can. So I'm going to start with a video just to introduce you to care, really, and give you a bit of a flavour of what we're about.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are care.
My name's Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex, we get single patients wanting to start a family, we get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualized treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us. So we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic, and even when I was ringing out with I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way, and I feel like they lived the journey with us.
So I've had several treatments with Care, and I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
So I think there was a bit of feedback on that video. Sorry about that. On the next video, I'll be sure to mute myself from the beginning. So as we said in the video, one of Care's messages, we really believe that family is for everyone, and 1 in 6 couples will need help starting a family, and we're here to support anyone that needs that help. So we help lots of different types of patients, heterosexual couples, same-sex couples, single patients, patients who want to preserve their fertility. And we think that by having clinics as widespread as we do across the UK, we can be in easy reach of most people in the country. So you can see our main clinics here in the purple text, and then we've got a few smaller clinics that we would class as our satellite clinics, where you would go for basic monitoring or blood tests, and then you'd have your main procedures in one of the big clinics that you can see in the purple text. So it's really easy to get started with Care. This is Shah, our General Inquiry Team Manager. We have a new patient inquiry team who are dedicated to supporting our new patients. They're very knowledgeable, and they can answer all of the questions that you would have about treatment and getting started. As I said before, they're here till 8 o'clock tonight, so if you have any questions, then get in touch. And Lauren, our new patient inquiry team leader, is as part of the events team tonight, answering your questions now. So the first thing that we need to do in your fertility journey is to get the right diagnosis. So we take the time to get to know everything about you. You might be completely brand new, have never been to any fertility clinic before, in which case we'll discuss with you certain tests that you might need to have to start the fertility journey. You might be a couple or a patient or who's been to another fertility clinic and have done tests before. So what we do is we set you up on our secure online portal, where we can share information between the two of us. So you could send us all of your paperwork, all of your test results that you've had from somewhere else, all of your medical notes. You can share all of that up onto the secure online portal. And then similarly, we can share information back to you about the treatments that we might think are appropriate for you. So we'll send you a detailed medical questionnaire that you complete on the portal. It's all digital, and all of the information that you upload and any information that you complete that we ask you to complete will be reviewed prior to the consultation that you have. So the portal can be accessed on multiple devices, so desktop computer, laptop, on your mobile, on your tablet. It has been made so that it's accessible on lots of different devices. And as I said, it's completely secure. You'll be given a unique passphrase, and only you will be able to access your portal. So once we've got all the information that we need, we would book you in for your consultation. So we have George here, who's one of our consultants from our Sheffield clinic. The consultation is the opportunity really for us to get to know you, listen to your wishes, what you want from the treatment, you know, what your family plans are, and to review your test results and decide if there's any further tests that we need to do for you. We'll discuss different treatment options, things that are relevant to your particular circumstance, and also the chances of success, again, that would be relevant to your situation. We'll give you really detailed information about the treatment options, so that will all be sent to you onto your portal, and we'll give you some of that verbally as well from the consultant. And that allows you to consider your treatment options in your own time, in the comfort of your own home, and you can decide how you'd like to proceed. We'll talk to you in that consultation about the support that we offer, the costs of the treatment, and we'll give you all the time that you need to ask questions. Obviously, they are slots of time that we give you with the consultant. So my advice is always write everything down before you go. If you think of questions in the run up to your consultation, just jot them down, and then you've got them at the front of your mind to ask during that time. So really, whether the problem is simple or whether it's complex, whether you've got tons of history and lots of complex things that go along with it, we've got loads of expertise across the group where we share knowledge and we can give you the absolute best chance of starting a family. So during this talk, I'm going to discuss generally the IVF process, and it might vary from patient to patient. Well, it almost certainly will vary from patient to patient, but generally most people will require the IVF process. Everyone is different, and we do individualized care, so some might not be relevant, but it will give you the general idea. So the first step in starting the treatment is the ovarian stimulation. So this is where we would prescribe drugs that you would administer yourself, and this would likely be for anywhere between 9 and 13 days. And these drugs are supposed to stimulate your ovaries so that we get multiple eggs developing in each ovary. Ordinarily, there would be one egg that would develop every month, but what we do with these drugs is try and stimulate more eggs in the time frame. So we would give you these drugs to administer. We would then monitor your response, and this is done via ultrasound guidance. So here's a picture of lovely Diane showing how to administer drugs. This is a video that you can find online, and we'll direct you to these videos, these what we would call an injection teach video, to show you exactly how to administer the drugs properly. And then, as I said, we do monitoring of your response to those drugs. So we would do 1, perhaps 2 ultrasound scans of the ovaries to see how they're responding, we would then decide when you would be ready for an egg collection. So we need to have a certain number of follicles at a certain size for us to be able to what we call trigger for an egg collection. And this trigger is a final injection that we give, which is supposed to do a final maturation, a final development of the eggs that are growing, and would trigger ovulation. It would be usually administered in the evening, and then the egg collection would be scheduled for 36 hours later, 36 hours after that. So the egg collection is a very straightforward procedure. It is done under ultrasound guidance, and a needle is passed directly into the ovaries very carefully, and the fluid from the ovaries is drained through tubing, and that fluid is then looked at under a microscope in the lab by one of the embryologists, and they'll be looking for an egg in that fluid. You can see on the screen here that we've got some ultrasound images, and the black areas are fluid filled, so that's where we would expect to see an egg. We don't always get one egg per follicle, but the follicle numbers give us an indication of how many eggs we're likely to collect. So the procedure can take 20 to 30 minutes. It will be followed by a short rest, and then until you're ready, you can rest for as long as you like, and then you're discharged and ready to go home. So obviously we once we've collected the eggs, we then need the other part to create the embryos. So this is the sperm sample that we need. So there's some images on here of some sperm samples. The sample is collected on the same day as the egg collection. Sometimes frozen sample might be being used, frozen sperm, whether that's donor sperm or partner sperm. Either way, we need the sperm on the day of the egg collection. So I think I have a video of some sperm swimming around to show you. So on this video, this is what we would call computer-aided semen analysis. So you can see the image on the left-hand side is sperm swimming, and then the image in the middle with the blue lines is the artificial intelligence tracking the sperm. And that tells us how well the sperm are moving. They should be moving at a certain pace in a certain direction for us to think that they're good quality. So that's what those blue lines show us. And then on the far right hand side, we get some information about the way that the sperm looks. So is the sperm moving in the right direction? Is it moving as fast as we need it to? And does it look good? So once we have the sperm sample and we have the eggs, we obviously then need to put the two together. And we do this through two methods. We would attempt fertilization on all eggs using the IVF process if the sperm sample is of good enough quality. So there needs to be around 200,000 moving sperm for us to proceed with the IVF procedure. And this is where we just put the prepared sample in with the eggs and leave them in an incubator overnight and let them do what they're going to do. The other method of fertilization or attempting fertilization is called ICSI. And that's where we would manually select a single sperm from the sample and inject that into each one of the eggs that were suitable. So the ICSI procedure is really for couples where the sperm sample is maybe a little bit lower in quality. There might not be quite enough sperm there, or they might not be swimming very fast, or they might not look as normal as we'd like them to, which means that the embryologist needs to just give them a little bit of a helping hand. So whichever method of fertilization we use, it's decided before the day of the egg collection, before the day of the fertilization process. But obviously, sometimes the sample that we get on the day is either much better than it was when we tested it beforehand, or it's gone down in quality. In which case, the treatment type could change on the day. It doesn't happen that often, but it's worth being aware that it can happen. So we then need to have a look at the signs of fertilization. But before I go on to that, I think that there's a video for me to show you for ICSI, which is really interesting. So let me grab that one. So this is the video where we manually inject a single sperm into each egg. So you can see the sperm coming down in the needle on the right-hand side, just a little dot. We push the needle gently into the center of the egg. We aspirate a little bit of the cytoplasm, the middle bit of the egg, just to make sure that we break that membrane, and then we deposit the sperm right in the middle and then move the needle out gently. And we would do this for every egg that was suitable. So it's unusual for all eggs to be suitable for the injection procedure, but it's usually around 80% that would be suitable. So if you had 10 eggs collected, 8 of them would likely be suitable for the ICSI process. So then we need to watch the embryos and see how they develop. So this is Alex, our lovely lab manager from London, and she's looking on one of our incubators, a time-lapse incubator. And this is an incubator that's fitted with a camera that takes an image of the embryos every 10 minutes. And this means we essentially end up with a video of the embryo development, and it means that we get loads of information about the embryo development, and it helps us decide which embryo is the best in a group. And it also allows us to manage your expectations as well. Has the embryo developed as well as we'd like over the course of the 5 days? And we can give you lots of information about the embryo development. So we keep an eye on the embryos over the course of their time in the lab, as much as we can without disturbing them too much. We like them to stay in the environment that they like, which is inside the incubator. It's nice and warm and it has the right gas concentrations. Whereas outside in the air outside of the incubator, it's a little bit colder and it doesn't have the right gas concentration. So we like to leave them where they are as much as possible, which is why these time-lapse incubators are so good, because it means we can get 24-hour surveillance and we don't have to take the dishes out. So there's 4 images on the screen here. You can see top left-hand corner is 20 hours after the insemination or injection. So we can see 2 little circles inside that what was an egg, and that indicates to us that that egg has fertilized. If we can see those 2 circles, that means we've got the DNA from the egg and the DNA from the sperm, and they've come together and they've created an embryo. Then the next image along on the top right hand corner is a 4-cell embryo. So it would be at this stage around the day 2 or day 3 of post egg collection. The bottom left hand side is around an 8-cell, so late on day 3. And then the bottom right hand is what we would call a blastocyst. And this is the stage of embryo that we would like all of our embryos to get to, but only the most competent embryos can make it to this stage. So more often than not, we take all embryos to blastocyst, which is around day 5, day 6 after egg collection. And this really gives us an indication of the absolute best embryos in the group that we have from you, so that we can give you the best chance of a pregnancy. So all the way through, we'll keep you updated, and we'll give you a call on the day after the egg collection, which is when we check for fertilization. And then depending on the treatment options that you choose, you may get a call halfway through around day 3, and we'll tell you how many of the embryos are doing well and how many might not be. And then we'd give you a call on day 5 to let you know how many of them have created blastocysts, and if there's anything suitable for us to freeze, if you're having a fresh transfer as well. So I've already talked a little bit about the time-lapse incubator, but what we have at Care is something called Care Maps. And this is a piece of software that essentially tells us out of a group which embryo is the best one. And this uses those images that the time-lapse incubator takes to tell us if an embryo has reached specific stages in development at the right times. And all of these images are then put into a piece of software that tells us on a scale of 1 to 10 how likely that embryo is to create a live birth, so to create a baby. So if you had 5 embryos and you opted for care maps, then we can tell you out of those 5 which one has the highest chance of creating a baby and what that chance is in terms of percentage. So the other treatment that we offer is something called Pgta. So this is pre-implantation genetic testing for aneuploidy. Now, everyone is different, and as I said earlier, we do individualized care, so these treatments might not be necessarily applicable to you, but Pgta essentially tests a small amount of the embryo for the chromosomes that it contains. So you can see in the image on the right hand side, there's some cells from a blastocyst being held in a needle, and we'll take those cells, we'll freeze them, and we'll send them to a genetics lab for testing. And that genetics lab will tell us if the embryo is chromosomally normal or not. So if we feel like you would benefit from Pgta, then at your consultation, the doctor will advise that it could be beneficial for you. There's other tests that we offer that you can read more about on the website. So we offer something called the Sperm Oxidative Stress Test and the Care Unity Test. And we obviously offer fertility preservation, so egg freezing and sperm freezing for anyone that needs it. So in terms of success rates, all of our clinics achieve fantastic success rates, and they do differ because it's largely based on the patient that you've treated, but you can find all of the information about success rates on the websites, and you can ask our events team as well if you wanted some specific information about success rates. So I've got a video to show you of the time lapse. So let me just pick that up. And this shows you, this is starting around day 3 of embryo development. This shows you the embryo's development going through day 3 through to day 4. This is around the day 4 mark post egg collection. And then it shows forming a blastocyst. So you can see that the embryo is starting to grow, and we can see that there's a mass of cells forming at around 4 o'clock. That's what we would call the inner cell mass. It's moving to a 3 o'clock, 2 o'clock, ending about 2 o'clock. And that inner cell mass is the part that eventually becomes the baby. So it's really important that we can see that mass of cells, which is why growing to blastocyst is really useful. And if you have chosen care maps, then you can have a video of the embryo's development all the way from fertilization through to blastocyst. So once we have decided which embryo is the best one out of the bunch, we'll then get you booked in for embryo transfer. And the embryo transfer is really straightforward. It's all done under ultrasound in most of the clinics. The embryos are loaded into a really soft, fine catheter, which is passed through the vagina into the cervix and through the cervix and into the womb. It's 10-15 minutes, and then afterwards you can go about your normal activities. You can rest if you prefer, but we tend to say just go about your normal life as much as possible. Once you've had the embryo transfer, it's the inevitable 2-week wait, which can be tricky, and it can feel like a lifetime. We will explain to you what you can and can't do in that time, and we'll tell you what date it is that you need to do your pregnancy test, and we'll make sure that you've got all of the medication that you need to help support a pregnancy during those 2 weeks if one were to occur. Your pregnancy test would be about 14 to 16 days after the embryo transfer, and once you have had that pregnancy test, get in touch with us and let us know either way. We're here to support you, whatever that outcome might be. And similarly, during those 2 weeks, if you want to pick up the phone and just talk to someone, then don't hesitate. If your pregnancy test is positive, great. The next step would be to book you in for a scan. So we would bring you in for an ultrasound scan about 4 to 6 weeks later, 4 to 5 weeks later, after your pregnancy test, and that will be to confirm that there's a heartbeat. And then at that stage, if there is a heartbeat, then we would discharge you into the care of your GP for standard antenatal care. Now, that's not to say that we're not here to continue the support after that point. You'll always be our patient, so you can give us a ring at any point throughout that journey. So that's the general IVF process in a nutshell. As I said, we do individualized treatment, so some of those things may not be applicable. You may be looking to do IUI with donor sperm. You may be looking to use frozen sperm, but in general, they're the main points of an IVF treatment cycle at care. So I'm just going to go through some other parts of care that are important. So we know that every different type of patient, every different combination makes a family. And so we're really, really good at donation treatments at care. We've got over 25 years experience in donor treatments, and that's with both donor eggs and donor sperm. And we've helped more people start a family with the help of a donor than any other clinic. So we're really unique in terms of donation because we have lots of donation teams across the group in each of our clinics, and those donation teams are really there to support you from start to finish in a treatment using either donor eggs or donor sperm. We have our own donor egg bank and we have our own donor sperm bank, which you can have access to if that was a treatment that you needed to have. We have specialist counsellors whose expertise lie in treatments with donated gametes. So we've got lots of expertise with donor treatments at care. We have got lots to offer in terms of support as well. So we have free counselling appointments to all patients. We offer a care buddy system where you can be buddied up with another couple or another patient going through treatment in the similar stage or a completely different stage, just to support one another through the process. We run regular support events. We did do lots of face-to-face support events, and they're coming back online. Or not online. We used to do walks and lots of nice things like that. And obviously the support is there from your clinic whenever you need it. As I've said, we have the clinic available, people on the phone for you to ring if you ever needed to. There is a 24/7 online forum, which is specific to care patients, and that's a really good place for some chat online with people going through the same thing. The other thing that we offer is funding options. So this is through our care pay packages. So these are exclusive IVF funding programs designed to make funding treatment easier. So we did used to outsource the funding, but the feedback that we got was that it was disjointed and it was difficult to marry up the two, the treatment and the funding. And so we decided to bring that in-house. It's less disruptive and we want to make it as seamless an experience as we can. So we do offer care pay packages for donor egg recipients as well. If you wanted some more information on that, then you know where to go. You've got all of the numbers, all the emails. You just need to get in touch and we can offer give you some more information. Included in every care pay package is the cycle monitoring, the egg collection, all of the embryological procedures, including embryo transfer and freezing and storage. You'd have unlimited embryo transfers, so that would be all of the embryos created if there are any frozen. We include blastocyst culture and care maps as well as an extra benefit to try and maximise the chance of success. So I think that's everything in terms of the presentation, I've heard lots of pinging going on, so there's obviously been lots of questions. We're going to do the Q&A session now with Professor Charles Kingsland. Hopefully he will join shortly. I'm going to try and get some questions up to see if we've got any that haven't been answered whilst Charles finds his way onto the system. He should be. Hello.
Hello, how are you?
Fine, thank you. How are you?
Good. Well, I'm pleased I pressed the right button there.
You made it.
I made it. There's a lot of questions here, Amy.
Yeah, tons. Do you want me to fire away with the ones we had beforehand?
Yeah. Do you want me to fire away with those? And
you go. Yeah.
Okay. So we'll start and see how many we can get through. Question 1. I'm a 39-year-old NHS-funded patient. If need to delay treatment, can you pay to freeze eggs for age retention? Well, my advice to you is if you're 39 and you've got NHS-funded treatment, it's probable that you're in a relationship. And my advice to you would be, if you want to delay conception, go ahead with the IVF, but don't have your eggs frozen. Have your eggs collected and fertilized, and then have the resulting embryos frozen. I think your chance of having a baby with frozen embryos at the age of 39 is higher than having your eggs frozen. So it's perfectly reasonable for you to say, can I delay conception by having my embryos frozen as opposed to eggs? Wouldn't you agree, Amy, at 39, yeah. Probably much better to have your embryos frozen. Of course, if you're single, then that's different. If you do not have a partner, then that might be different. But I think NHS funded treatment would imply that you have a partner. How long does it take from funding approval to starting treatment? That depends entirely on your CCG. CCG stands for Clinical Commissioning Groups, and they're the groups, the healthcare providers that give hospitals and clinics the money to provide your NHS treatment. So it varies from region to region. Post-COVID, it's a lot longer than it was before. So you might be waiting 3 to 6 months, or it might be 2 years. It really depends on where you live, and this is the postcode lottery. If you're funding the treatment yourself, then of course it should be fairly rapid. And clinics, in care, for example, we would be offering the treatment in a very short space of time. Really, just as long as you've got all the tests together and the consent forms, then it should be fairly quick. But NHS depends on your CCGs. Can you have IVF with ovarian cysts? Well, the answer is yes, you can. Of course you can, because a lot of problems with IVF lie, a lot of the conditions that are treated by IVF can cause ovarian cysts. Now, the issue there is what type of ovarian cyst it is and how large it is. And depending on the size and the pathology of the cyst, that means what sort of cyst it is, it might be better, your gynecologist or your fertility doctor might advise you to have the cyst removed before your IVF, because that gives you a better chance. If it's a simple cyst and it's less than 5 centimeters in diameter, at the time of your egg collection, you can just have a needle punctured into the cyst and have it drained, and it's as easy as that. So it really depends on the nature of your cyst. Do you transfer mosaic embryos? That's one for Barrie, I would say.
Good question, and a complex question. Yes. So mosaic embryos mosaicism is something that we only find out if we do pre-implantation genetic testing, which is the Pgta. And what it means is the cells that we have sent to the lab for testing, some of them have come back as normal and some of them have come back as chromosomally abnormal. And that is supposed to reflect the embryo as a whole. So that would indicate that perhaps the embryo has got a portion of the cells are chromosomally normal and a portion of the cells are chromosomally abnormal. And you can have different grades of that mosaicism. So you can have low mosaic, which means that there's more normal than there are abnormal, or you can have a high mosaic, which means that there's an equal proportion or potentially more that might be abnormal. So we can transfer embryos that have been classified as mosaic. We would require you to have genetic counselling, because we obviously need you to understand the implications of what that means. And the success of a transfer of mosaic embryo might be a little bit lower. So we can, with the proper information and counselling.
Oh, very good.
Next.
I thought you were going to take about half an hour to explain that one, but you did so well. Now, this next question I find fascinating, and it's one of the things in IVF that still fascinates me. This couple have asked, how does a single embryo result in twins? Seen this from a fellow IVF account on social media, and I'm fascinated. Well, when you get non-identical twins, that means that 2 eggs have been fertilized by 2 separate sperm. Identical twins is where 1 sperm has fertilized 1 egg, and then that embryo at a very early stage in its development has split down the middle into 2 and has created 2 separate individuals, and that's where you get identical twins. And similarly, when you have IVF and you put 1 embryo back, that embryo can rarely, but it can split into 2, and then you get a set of identical twins. They're identical in every way. But the interesting thing about identical twins is that even though naturally they come from 1 embryo, and with IVF they come with 1 embryo, they are 5 times more common with IVF than with natural conception, and nobody knows why. It doesn't mean that they're in any way different, because they're still identical, but it happens 5 times more often in IVF. Isn't that right?
Yeah, that's right. Yeah, it's very interesting, very fascinating, and it's heavily researched by lots of people to find out why.
And it's one of those things that differs between natural conception and IVF, but it's one of the only things that's left, because IVF babies, if you take into the age of the female, are in every way the same as naturally conceived babies. People have often said, "Oh, IVF babies are somehow different." They're not, but you do get a higher incidence of abnormalities in IVF babies, but that's dependent on the age of the female. If you're 38, you're more likely to have babies that are affected by abnormalities, which can be screened for, but it's nothing to do with the IVF. It's to do with the age of the patient. Mild or natural IVF, how does your treatment differ from that? Well, this is another one of my hobby horses. I'm not sure what mild or natural IVF is, but well, I'm just being a little bit facetious there. But one of the principles of medicine is that you do as little as possible to help the patient. So you always offer the mildest treatment. If you have a particular infection, you offer the mildest antibiotic, which will effectively treat the patient. If you do an operation, you do the least invasive operation to do the maximum amount of benefit. So if I said to you, if a patient was coming in for having their appendix removed, and I said, we're going to do a mild removal of your appendix, you think I was daft. It's exactly the same with IVF. That's what IVF is. It's mild. We want to do as little as possible to create your family as we can. And, natural, so we give you the lowest dose of drugs to get the maximum benefit. There is no doubt, there is clear evidence that the more eggs you get, the more chance you've got of creating embryos. And therefore, if you've got more embryos, you've got more chance of getting a baby. The optimum number of eggs, which has been shown in countless studies, is 15. We know that 15 eggs gives you the best chance of having a baby. Of course, you can still have babies with 10 eggs or 20 eggs or 1 egg, but 15 is the optimum. Now, natural IVF is where we don't stimulate the ovary and we just monitor the growth of 1 follicle and collect 1 egg. Okay, from what is a natural cycle. There's nothing natural about putting a needle in an ovary. That's unnatural, but that's what you're here for. We are trying to help you achieve a family, and therefore there are going to be interventions. We want them to be as mild as possible, but it's obvious that you have one egg, your chances of getting pregnant are going to be less than if you've got 2 eggs. But with mild or natural IVF, then you can come back sequentially, and probably the next month you'll have another egg collection, and the next month. It takes longer to accumulate the eggs, takes a longer amount of time, and eventually you will have the same amount of treatment spread over the same number of months. But what we're trying to do, we're trying to individualize your treatment to give you the best information to give so that you can make an informed choice as to what is best for you. And that's not only the treatment, that's the financial implications. How much is it going to cost you to have this treatment? You know, if you have one egg collection for one egg 15 times, that might be more expensive in the long run than having one set of stimulated egg collection. So it's important that you know exactly how much it's going to cost, how long it's going to take, and what are my chances of success. So then you can make the informed choice. So you get no nasty surprises at the end when you go, well, I've had natural IVF, it didn't work, but now I've been asked to spend X £1,000s on less natural IVF or mild IVF. Well, I never knew about that. Well, it's our duty to tell you, our responsibility to tell you how much it's going to be before you start, to give you the best individualized chance to have a baby. IUI for single women and donor sperm. Well, there should be quite a bit about that on our website, but generally speaking, yes, we offer IUI for single women. IUI stands for intrauterine insemination. This is where we get donor sperm, which has been selected by yourself. We would give advice as to where to source the donor sperm. It could be from our bank, or it could be from a bank in Europe or a bank in America, which we would support and advise you as to how to get the best quality sperm with the characteristics that you want. We will then import that sperm and save it for you. And then what we do then is we monitor your cycle with ultrasound scans, and at the time of your maximum fertility, we will take a sample of that sperm, we will thaw it out because it's been frozen, and then we will inject it into your cervix. So we take a very fine catheter and just thread it into your cervix, through the vagina into your cervix. It's quite painless, and then we slowly inject the sperm as high up into your uterus as it will safely go. And that is one cycle of intrauterine insemination. Depending on the quality of your sperm and the quality of your uterus, which will have been assessed by scan, and your antral follicle count or your egg count, we will be able to give you an estimate of what the likely success is of you getting pregnant per cycle of treatment. And we will review you after every cycle to see if there's anything we could do better or anything that needs to be added to give you a better chance. Is that right, Amy? Is there anything you'd like about that?
No, that's perfect. We had a request to go to talk about IUI, so that's perfect. There was a question that came through from a couple. She says that her husband is unable to ejaculate during intercourse, and ejaculation via masturbation is fine, and the sperm test is good. Is IUI a viable option? Yes. Yeah. Perfect. IUI would be perfect.
And that is a common problem, in heterosexual couples, men having to ejaculate to order. It can be and we notice this when they come to the laboratory, Amy, to produce samples. It's a pretty stressful situation, and performance can be affected by stress, and even during intercourse. We see many couples that have difficulty with ejaculation or sexual performance, and that's okay. We deal with that, and we can provide support. And if it's IUI or counselling or just general psychological support, then we're there for you.
Yeah. So the questions that have come through on here. So my husband has a low sperm count and has a prognosis of severe oligospermia. Some information such as sperm morphology and sperm vitality and sperm antibody assessment couldn't be performed. Would care be able to provide this information from a semen sample with such a low sperm count? Probably not. So the reason that those tests couldn't be done is because the sperm count is so low. So we need to be able to count at least 400 sperm to assess morphology accurately. So what we can do is look at the sample and say we've seen 20 sperm, and of those 20, 10 look normal. So really inaccurately, maybe 50% of them look okay, but that's going to be really difficult to say with any certainty. We really need to be able to count 400 sperm, and that's the same with all of those tests. Really, you need a really good number of sperm to give an accurate result. So we can certainly look at them and give you the information. We'll just give it to you on the proviso that it's likely to be a bit inaccurate.
Can we use that sperm with IVF and ICSI?
ICSI, we can use that level, that concentration of sperm, as long as we've got some sperm there. I mean, sperm count of 0.1 is fine. We can do ICSI on that. Yeah.
So we might not be able to do the full assessment,
no.
But there's a strong possibility that we can help you to conceive with that low.
Yeah, absolutely. And when we do the ICSI procedure, we look at the sperm under a really high-powered microscope. So we can pick the ones that look good, the ones that look the best. And that's one of the good things about ICSI. Yeah,
that's so treatment is still an option for you, even though we can't do the full assessment. There's a question here about duostim.
Yes.
Duostim is a relatively new technique, and it's essentially for patients or for women who have a low egg count. And what we want to try and do is to stimulate the ovary to create as many eggs as we safely can. And when you've got a low egg count, that's normally quite difficult. And often we find that eggs will grow at different rates, or follicles will grow at different rates. And so what we do in these cases where the egg count is quite low, we will stimulate the ovaries, collect the first batch of eggs, but then continue stimulating the ovary so that the smaller ones are stimulated, and then we go back and do a second harvest a few days later. So it gives us the best chance to get as many eggs as we possibly can in these cases where there's not many eggs knocking around, and then we can fertilize. We fertilize the first batch, freeze them, we fertilize the second batch, and freeze any embryos, and that gives you probably a better chance of getting pregnant.
Yeah, and it's specific for certain patient groups, isn't it? So we would recommend it for those ones that the AMH is particularly low, or multiple failed treatments, and we can see from previous treatments that there has been that lower cohort of follicles developing that we could pick up in a second round of stimulation. So Dr. Vicky Sefton and I did an Instagram live on that maybe 4 or 5 weeks ago, and it should be on the Care Instagram page. If anyone was particularly interested in duostim and wanted some more information, you can watch that back, and that should go into a bit more detail.
I know. I do know that Dr. Sefton, who is our medical director, and Vicky and Amy, our head of laboratories, have done a lot of pioneering work on duostim. So I can honestly say I'm sitting in the presence of a duostim expert.
Okay, I have extremely low AMH levels, 1.7. Is it still possible to retrieve an egg and even get pregnant naturally? I appreciate these chances are still low. However, in your opinion, is it worth another attempt? Age 36.
Well, AMH gives you an indication of egg count. It tells you nothing about the egg quality. What tells you about the egg quality is your age. I've said this many, many times, but women are egg warehouses. They don't make new eggs. So if you're 36 years old, your eggs are 36 years old. So it's actually much better to have a low AMH and be 20 than a high AMH and be 40. Because when you're 20 with a low AMH, you've got a low number of 20-year-old young eggs. Whereas when you're 40 and you've got a high AMH, you've just got a higher number of 40-year-old eggs, which are less likely to be fertile than the 20-year-old ones. So it gives us an indication in IVF as to how your eggs, how your ovaries will respond to stimulation. It doesn't tell you much about your chances of having a baby. So what will if you'd have had IVF once with an AMH of 1.7 at the age of 36, that will tell you what your likely chances, if it's been unsuccessful, of another cycle of having IVF. And really, before you go ahead with another cycle, you need to be counseled by your doctor or nurse practitioner to give yourself the best idea as to what my chances of success and how much it's going to cost me, so that you can correlate the two and see whether it's in your interest to do that, or whether it's time to move on to another chapter in your treatment, which might be more successful, or to do something else entirely. But you need all the information before you go ahead. And have I seen women with the age of 36 with an AMH of 1.7 having babies? Yes, I have. Yes, I have.
Yeah. Is there anything in that vein? Is there anything that can be done to increase AMH levels? And does DHEA work?
No. So DHEA is dihydroepiandrosterone acetate, which is a hormone that is a building block for estrogen. And so the theory is, you take DHEA, it might stimulate estrogen production, which might improve the quality of your eggs. Now, that in theory is a good idea. DHEA is not expensive, it's not harmful, but what you need to know is it of any benefit? And there have been lots of trials with DHEA, and in fact, none of them have really shown a significant improvement in outcome. It won't harm you, so therefore it's, if you feel like you want to take it, then fine. If you want to rely on the theory, but in practice, will it be of any benefit? Then the jury is out. DHEA is not a particularly expensive treatment, so it might be worthwhile trying. In the same way that testosterone priming might be worth discussing with your doctor. And there are lots of other things that you might want to consider. Just general lifestyle. If you're overweight, try reducing your weight, better diet, stopping smoking, making sure you take your folic acid. All these things can be of benefit, and they are every bit as successful as taking DHA. In the same way as acupuncture might help you, Reiki therapy might help you. These are all things that are of that may be of help. They haven't been proven scientifically, but as long as they're not harmful. Now, if you said, I'm going to take, half a pint of snake oil because I've been told that's a benefit, well, that's not only not a benefit, but it can harm you. So these are the things that you've got to try and be wary of, that you might be recommended, whether it be on social media or by friends or by some other practitioners. If you need a clear advice as to whether they will be of benefit, but clearly if they are harmful, and I include very expensively harmful, then you should avoid them.
Yeah, and you said, didn't you, that there isn't anything that you can do to increase AMH levels? It is what it is. It's not going to change.
All you can do is turn the clock back, and we haven't sort of
cracked that one.
That one.
No. Okay. Do you help people who aren't currently ovulating before going down the IVF route?
Of course we do. That's the whole purpose of getting informed advice. We want to do, harking back to a question that we mentioned before, the minimum amount of intervention that give the maximum benefit. So if you have anovulatory infertility, so your partner or you have access to normal sperm, you have a normal healthy uterus, a normal egg count and you're just not ovulating, you're not releasing an egg predictably, then there are lots of medications. The classic one is Clomid, that will get you to ovulate. And given a fair wind and if you're of the right age, then the pregnancy rate after 6 months can be as high as 50% if an ovulation is the only thing. But you have to be sure that that's what you're dealing with. Similarly, if you have unexplained infertility when you're ovulating, so you're producing an egg and your uterus is healthy and the sperm that you're using is healthy and your tubes are not blocked, then using Clomid is of no benefit. So by saying, oh, well, can I, I've got unexplained infertility and I'm ovulating, can I use Clomid to help me? No, Clomid will not help you. Clomid treats anovulatory infertility. Very effective when you're not ovulating. No benefit whatsoever. Not particularly harmful, but you could argue that you're wasting time, and time when you're trying for a baby is of the essence.
Yeah. How do you manage the impact of certain conditions such as endometriosis and a major ovarian cyst on the success of IVF? If one ovary is blocked by an ovarian cyst by laparoscopy, what effect does it have on the number and quality of eggs produced?
Well, it depends on the size of the endometrioma and how much damage it has caused. So it may be of benefit to have that endometrioma removed or your endometriosis reduced to prevent complications of IVF. But generally speaking, having cysts removed, if they are less than 5 centimeters in size, is of no benefit to the outcome. And there are some studies that suggest that endometriosis treatment before IVF won't necessarily improve your prognosis. It might improve your symptoms, which is very important if you get excruciating pain, because endometriosis can be a very, very unpleasant disorder to have. So it might be worthwhile treating as much endometriosis as possible before you go for your IVF treatment. But if you've got mild mild endometriosis, it's not going to be a benefit to you to have definitive treatment for your endometriosis. Just crack on and get your IVF done.
Yeah. With Pgta, is it only chromosome number abnormalities that can be seen, or can you delve deeper into translocation mutations? We can. There are 2 other types of Pgt that we can do, and they are Pgtm and Pgt Sr. And they are exactly that. They delve deeper into what's going on in terms of the chromosomes themselves. So Pgta is something that we can do in all of our clinics for any patient that wants it or would benefit. And that tells us about the chromosome number and the chromosome number only. We can do these more in-depth Pgts in certain clinics because you have to have a special license to be able to do them. And we also have to have a reason for doing that test for you. So you maybe know that you're a carrier for an inherited disorder, or you maybe know that you carry a translocation and you want to rule that out in any subsequent embryos. So yes, we can do those technologies, just not everywhere. In certain clinics we can. Is there anything that can be done to increase sperm count and quality? Well, lucky for men, I feel like they can do something to help with their sperm count and quality. So lots of things in terms of healthy lifestyle, which women can do as well, and which will help. But stopping smoking, making sure your weight is under control. Don't do excessive drinking. But one of the things that we can do at Care is the sperm oxidative stress test, and this is something that's quite relatively new. And we can test whether your sperm are stressed or not. And if they are, then we can recommend you taking some supplements, some antioxidants that will reduce that stress on the sperm and therefore increase potentially the number of sperm and the quality of the sperm. So it's really tempting for guys to go into a Boots and pick anything off the shelf and say, oh, they're going to help me, they're going to increase my sperm. But sometimes those kind of supplements can do more damage than good. So it's really worthwhile having a test beforehand, such as the oxidative stress test, to tell you whether those supplements are going to help or not.
I think that's a very important point, Amy. You know, when you're trying for a baby, women will obviously need to take folic acid, because folic acid unequivocally is a benefit, has been proven a benefit to helping you achieve a healthy live-born baby. But that's not the case with men. Don't just go to the chemist and think all vitamins, minerals, zinc, vitamin E are going to help me, because they can actually harm your sperm. The only thing I'd add to that, Amy, is, you know, make sure all your if you have any chronic diseases or hypertension or diabetes, make sure they're as tightly controlled as possible. And sperm like being produced in the cool, so keep your testicles cool. And the other thing, we get an awful lot of young men nowadays who come along having taken steroids to enhance their performance in the gym or in sport. Sperm, that may be great for your testosterone levels and great for your fitness, but it ain't good for your sperm.
No. Right, last two questions, I think, because we're getting on. So could you explain more about OHSS, please?
Yes, ovarian hyperstimulation syndrome is a complication of IVF, where unpredictably the follicles grow far quicker and far more rapidly than you anticipated. So you get multiple cysts growing on your ovary, which can then leak fluid and draw fluid out of the rest of your body. So you actually get fluid leaking into your tummy, but you're actually getting dehydrated as the fluid is trying to replace that fluid leaking out of your ovaries into your tummy. So it can set up a whole set of biochemical anomalies that can make you mildly or moderately or quite severely unwell. OHSS is an only complication of fertility therapy. You can't get it from anything else, and it used to be fairly common. Nowadays, fortunately, with the advancing techniques, it is exceptionally rare, and we can, together with being able to predict it, we can actually institute treatments that can virtually eradicate ovarian hyperstimulation and take that significant risk away from you. But nowadays, most clinics will be running, will have a report OHSS rates of less than 0.5%, 1 in 200. And the vast majority of those will only be mild. So you might get a bit of bloating, a bit of nausea, and no more than that. However, we've always got to be guarded to prevent the moderate or severe. And to a large extent, we've eradicated that in the same way that we eradicated twin pregnancy, because that's the second commonest problem. And by replacing high quality embryos singly, as opposed to 2 or 3 embryos like we used to do many years ago, because people tend to forget that twin pregnancies are fraught with danger. We always see the happy, healthy twin pregnancies being wheeled around in their pushchairs, in their double buggies in the supermarkets, but you don't see the ill, the dying, and the dead twins that we will see in the hospital. So we try and avoid twin pregnancies in the same way as we avoid OHSS.
Yeah. And last one, I'm 39. Should I freeze my eggs?
Well, it depends whether you've got a partner. If you're planning on a pregnancy and you found the partner of your dreams, crack on. 39 freezing eggs is not as successful than if you're 34 and freezing eggs. So I would be hesitant, Amy, about advising a female to freeze her eggs at the age of 39. Much better to freeze embryos.
Embryo freezing is the embryos definitely survive much better, and we know that. It does completely depend on your individual situation. You know, you can come and talk to us about it, and we can advise you on what would give you the best chance of having a baby in the future, which is likely to be freezing embryos. But if you're not in a place where you want to pursue that as a single patient, or you don't have a partner that you feel ready to do that with, then freezing eggs might be an option. Yeah. Fabulous. Well, thank you very much. That was a lovely Q&A.
Thank you, Amy, and thanks for inviting me, and thank you to all of you for taking the time out of your evening to watch us. And I hope it's been helpful, and good luck.
We'll see you soon.
See you soon. Bye, Amy.
Bye. So I'm just going to end with a short video, just to again give you a bit of a flavour for care. I hope the event has been really helpful. I hope you've had all of your questions answered. If you think of any more, you know where we are. Just get in touch, and we hope to see you soon.
I'm Shah, and I manage Care's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So, if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose Care was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of, well, one size fits all, but with Care that didn't seem to be the case at all. They took everything into consideration, and they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and, you know, fingers crossed, will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to Care.
Oh, the support at Care was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what Care can offer you. To provide you with the best care possible and to give you your best chance of success in treatment, we look to our own care family. From our consultants, embryologists and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, And that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are care.